The best artists, innovators, and creators know you can't rush quality. It takes time. Quality doesn't come overnight, from a fluke or from a split-second encounter. It takes trial, effort, craft, and precision. It never comes from your first question, your first answer, thought, or idea. It takes longer, days, months, even years. Quality is never finished from the first stroke. You have to look, touch, feel, mold, and reshape to find that inspiration, to reach the extraordinary. And from over 20 years of inspiration, we have been perfecting every breakthrough, putting our knowledge, skills, and expertise into our work to become the best in the aesthetic industry. With our German engineering pedigree, our years of experience in hyaluronic acid products and patented technologies, we will continue to invest our time to push the quality of our products, because quality of craft means impeccable beauty. Bioscience, the beauty of quality.
Hello, everyone, and welcome to the fifth episode of Bioscience webinar series, the Aesthetic Mastery. My name is Dr. Carmelo Crisafulli, and I'm an Italian plastic surgeon based in Dubai. And as the moderator of today's session, I would like to extend a warm welcome to all of you. Thank you guys for coming. Bioscience has organized this event with some of the best international experts to educate and spread awareness regarding the safety of hyaluronic acid fillers for gluteal correction. Personally, I've been using AH fillers for about 5 years now, and after more than 3,500 injections, I can say that I strongly believe in the procedure and I strongly like the product. So, quick introduction about the company. Bioscience GmbH is a German laboratory that has been pioneering the field of aesthetic medicine since 2001. Their exclusive partnership with ISAP since 2019 is built on two main values that they have in common: excellence and safety. Bioscience is particularly driven to ensure the highest standard of patient safety and scientific excellence. The company is not only manufacturing the world to hold the CA certification for both facial and body fillers since 2014. We know that the demand of the buttocks augmentation minimal invasive procedure is growing each year. And in fact, buttocks augmentation procedure experienced a growth of about 39% between 2018 and 2019. Dermal fillers have become the ideal solution for those looking for minimal invasive and safe procedure with no downtime and immediate results. What's more, they can be used in combination with other surgical procedures like liposuction, lipofilling, and implants to reach the best results possible. And Bioscience has organized this session with renowned experts and to educate and spread awareness about the safety of hyaluronic acid fillers for gluteal correction. In line with this vision, we are proud to bring you today's symposium, which we hope will be an insightful experience for you. So let's talk now about the agenda. In today's episode, you will gain a unique insight into the safety parameters for gluteal volume correction with hyaluronic acid fillers. First, you will hear from the ISAP National Secretary and Plastic Surgeon from UK, our friend Dr. Naveen Kavale, on applying ISAP's safety guidelines in daily practice. Dr. Henry Delmar, ISAP's member and plastic surgeon from France, also join us, and they will share with us some insight of the anatomy, its technique, and safety recommendations for hyaluronic acid gluteal filler. Next, Dr. Ahima Sundaramam, board-certified dermatologist from the US, will deeply dive into the hyaluronic acid filler science and rheology, And then there will be a time for debating with an open discussion where Dr. Massimiliano Brambilla, Italian plastic surgeon, member of Bioscience Scientific Board, will join us. Last but not least, we will finish the session with a round of question and answer from our audience. So before we start, if you have any questions during the lecture, please type them into the question and answer box at the bottom of your screen, and we will be answering some questions at the end of the session. If times run out, we promise that our team will get back to you by email with the answer to your question. Let's begin today's session with the ISAPS National Secretary and Plastic Surgeon from the UK, Dr. Naveen Kavale, who will explain the application of ISAP safety guidelines into our daily practice. Welcome, Dr. Naveen, and thank you for joining us today.
Thank you very much. It's a pleasure to be here, and I'm going to keep my talk very short, very sweet, because I think, as you said, the collaboration with ISAPS and bioscience is to do with excellence and safety. I certainly don't sit here and pretend to be one of the people who's a practitioner of excellence when it comes to fillers, either in the face or in the body, but I can certainly tell you about safety and the ISAPS take on it. I'll quickly share my screen, I hope. If I go to there. Basically, I'm a plastic surgeon in London. I'm also, as you said, the National Secretary for the UK for ISAPS, and more recently I've become the social media chair as well for ISAPS. And it's very easy when it comes to aesthetics to concentrate on the exciting, the beautiful pictures, the nice videos, the aren't I wonderful, aren't I great. The trouble is, when it comes to safety, it's the boring stuff that we've got to concentrate on. But the boring stuff is really, really important, and that's what I'm going to try and tell you guys very quickly. I won't dwell on all of this for too long, but these are generally the principles to which I guess any good doctor, and that's what really safety is about. It's about being a good doctor, whether you're a surgeon, and a physician, a nurse practitioner, or an allied professional. We're dealing with want stuff. It's not need surgery. We're also dealing with business. This is not public health. People are paying for this, and we're doing it quite often to make money, but we shouldn't let the dollar signs cloud us and start taking over. At the same time, we are also vulnerable. We're the people these days, especially in the UK, America, the USA has calmed down a little bit when it comes to the medical legal side. The UK is going up, if anything, and so that's an extra stress. It's an expensive business as well, certainly in the UK. We're also, having to keep in mind all of the sort of pressures that you have from society, especially for the patients, but actually us as surgeons, we're all trying to compete with each other. We're all trying to manage our egos. It's not an easy business. And as well, in the meantime, the legalities of doing all of this, the UK is very, very dodgy when it comes to certainly filler regulation. We've had our fair share of scandals. But when it comes to fillers in the UK, it's totally unregulated. Anybody can inject fillers. You don't have to be a doctor because fillers are classified as a device in the UK. So, don't be one of the dodgy practitioners, be one of the good guys. In the meantime, it's try and collect data, try and publish data, it's difficult. It's really, really difficult to get objective numbers and data, but what, I would encourage everybody here to try and measure somehow objectively rather than just subjectively, which is what we tend to do. Getting evidence in plastic surgery is very, very difficult. And yes, publicize what you do, and push it out there, but be careful. I'm not going to, again, as I said, I'm not going to dwell on all of this. Deal with your complications, okay, because problems happen. Do it safely, do it openly, don't do it alone. Deal with complications with your peers. ask for help. And then I was just going to end with really the basics of what we push in ISAPS, which is, spend time talking to your patients before you start plunging the knife into them or the needle into them. Make sure you have consulted with them several times if need be before you go ahead and start treating them. Do the basics really, really well. One of my favorite sayings is do the ordinary things extraordinarily well. Document stuff, write it down, because then there's a record if you do have problems. Photographs, probably everyone here is photographing, but make sure you photograph properly, objectively, and learn how to do that properly. And never, ever, ever compromise on the basic principles of being a doctor. Know your limitations, know your stuff, know what but at the same time, know that you don't know everything, okay, which is kind of what this is trying to say on the screen. Apologies for the language. But I think if you do have problems, it's not necessarily the end of the world. Complications and problems and difficult patients are there to teach us so that we can go on to do things better next time, and share your problems. This is one of my favorite sayings as well from one of my old bosses is, make your worst complications your best friends. And actually, if you do treat your complications well, then they will become some of your best advocates. And when it comes to, this is not necessarily just about surgery. This is about actually anyone who does any intervention. We all know how to do it. Again, and here you will learn how to perform, for example, filler into the buttocks safely. But actually, the real skill is deciding when to do it. And then the real skill is knowing when to not do it. And that's difficult. That takes a lifetime to learn. And actually, at the same time, don't forget that you're a doctor. You may be an anesthetic injector, a surgeon, a nurse practitioner, or whoever, but actually try and be a physician first and foremost, a holistic doctor who happens to be operating. In the UK, we have these guidelines from our college. Follow your local guidelines, follow the rules, and never ever compromise. Don't try and cut corners just because of the pressures that I've mentioned. Keep true to your basic principles. Stay safe. And if you need help, ask organizations like ISAPS for guidance. By all means, I did see a Q&A, actually. Someone was saying, can I have contact details? This is my email. Please do get in touch with me. You can find me on social media, and you can find me through ISAPS. That's really all I was going to say, actually. So yeah, good luck out there, and thank you for inviting me.
Thank you very much, Dr. Naveen. Thank you. It's quite interesting as in every country in the world, there is a different regulation about something that isn't on our daily practice. Well, let's proceed. We will keep question and answer for the end of the debate. And I would like to invite Dr. Rellenos de AH. He will talk about his own technique about the correction of the buttocks with the...
Hello, Carmelo. Thank you.
Hi, Henry.
So I'm very happy to share a short experience, and I hope that the question can help us to go a little bit ahead. So my topic on surgical, non-surgical gluteal volume correction with hyaluronic acid, technical and safety aspect. So I'm plastic surgeon, south of France, and I'm working in the clinic you see on the picture. I try to go on the next slides. Yes, so the alternative are liposuction with gluteal fat transfer. The pro that is we can reshape the body. They are permanent, biological, good integration, and can be placed freely. Cone are traumatic surgery, more adverse events, biologic dynamic change in body fat, softer and lower projection capacity, long recovery time, and limitation in resources. The other alternative is implant. Pro, it's form stable, permanent shape, strong lifting capacity, but it's a traumatic surgery with important adverse events. There is a scar, there is a long recovery time, and mostly the implant do not match with the aging buttock. And you can read on it thanks to Dr. Orange's articles. So for filler, good filling capacity is done in office with a minimal traumatic treatment, low frequency of adverse event, short recovery time, it's reversible, adjustable, diverse, flexible, invisible scar, but it's not permanent, which can be as well a good thing. The price is part of the deal with the patient and is non-form stable. We will treat these 5 different subjects: the anatomy, patient selection, safety, and correct aftercare. The anatomy, the overall shape of the buttocks depends on the bony framework and the gluteus maximum muscle, the location and the amount of the subcutaneous fat, and the tightness of the skin. The buttock frame with a gluteus maximum muscle detached. And we can see that the bone frame is something which is important to understand before doing a treatment. Another thing that we learned from fat grafting, that if you go in the muscle, you have a lot of risk of embolisms, and that can be dramatic when we perform an aesthetic procedure to have a too high level of adverse event, and that is a dramatic one. So avoid to be too deep, avoid the muscle, and be only at the level of the subcutaneous tissue. How to do your marks on the buttock? And I like to do like a painter taught me. The first thing is to mark. There is some slowly to spend. So we have some mark. The first one is a triangular with a dimple and the line of the buttock. The line of the sacrum, the line of the trochanterus, and that design parallelepiped. And the most of your part of your buttock is in this parallelepiped. And we can see in transparency the design of the bone. And when we have a male buttock, the rectangular becomes a square. The classification system for gluteal evaluation from Mandetia is quite interesting because that's helped to understand the relationship in between the sacrum and the trochanter. So the A shape, the V shape, the short square buttock, and the round buttock. Patient selection, the best quality of the treatment is when you have a low BMI with a good quality of skin quality, realistic expectation, natural result, and the patient is agree, with the budget of the treatment, and also the patient give you their her or his acceptation on how to observe the follow-up. Easy to understand when you have a high BMI, but the quality of the result will be insignificant because all the product will be diluted in the fat and you will not see any result. Another thing is the stretch test. If the stress distance, or can you back? Okay, thank you. If the stress distance of the skin is increasing by 15% or more, then there is a probability to too much laxity, and treatment with HA is contraindication. Not really a medical contraindication, but that means that the result you will achieve will not be adequate, and the patient can be disappointed. When the pin stage measure with a calapter show that the thickness of the skin is lower than 2 centimeters, then you have as well a bad indication. The safe product is a key of the quality of the result. The hyaluronic acid characteristics should be different from filler depending on the indication in terms of molecular dimension and resistant to enzymatic aggression. The injection technique should be defined to avoid fast resorption and side effects. The one we select is Yarcore. The cross-linking is 20 milligram per millimeter, and the particle size are very big. 200 to 350 for the MLF1 and the MLF2 up to 500. The two things which is important to remember is IG prime and the low 10 delta. How to proceed to a safe procedure. So the planning in pre-anesthesia, we mostly use the amoxicillin 1 or 2 grams 1 hour before the procedure per os. Of course, picture and videos, planning, markings with the patient stand-up, planning the maximum of the volume you can project and the budget for that, and as well annual project, because as you have some resorption, and it's not only a one shot, then explain your patient, educate your patient to spend a amount of money dedicated to the Botox augmentation. And of course, the pre-treatment contract, sign the consent and the adhesion of the patient in the follow-up. So here, what I do, I mark my dimple, go to the line, and that marks the triangle. Then the sacrum, the upper part of the sacrum, laterally, the trochanter on both sides. It's not sometimes you need really to focus on this determination. You make a line, a straight line, horizontal line, and you connect all these different points. And in the parallelepiped, you have the maximum projection you want to achieve on your Botox. Then you feel by the contraction of the gluteus, the upper part of the gluteus, and then you can design the roundness and the shape of the upper part of the Botox. And that gives a guideline also to design the lower part of the Botox. In this case, we focus only on the 2/3 of the Botox. that the lower limit, and we also design in intermediate the transition zone, where you put a little bit less of product to avoid to design a soft transition zone. One of the most important things, if you want that your patient come back, is to be able to transform this procedure in a comfortable one. So anesthetize the skin of the entry point with a very small gauge, 30 gauge, and when you have the skin blanching with lidocaine and epinephrine, then start the infiltration of the subcutaneous fat with 18 or 20 gauge, but a quite long cannula, 90 millimeters, and you can inject 50 cc per side, combination of bicarbonate and lidocaine. And the fact to dilute allow as well to increase a little bit the thickness of the subcutaneous fat, and that allow you to be more precise in the location of your injection. Why I prefer the 16 gauge? Because it's easier to inject the product, so the extruded force is easier, and also you control better when you have a stiff cannula than a soft one. You control the tip of your cannula, and then you can drive it exactly at the location where you want. And you do not let your cannula go by itself anywhere, sorry. So advice is to limit the volume of the injection to 150 cc per session. With ultrasound guideline, it's not what I do, but for the first time, it's good to use it and to know exactly where you feel and when you see the tip of your cannula, and work superior to inferior, but that is something that is more personal. And the system, the FSFS of Lockwood, is representing by the dermis, the superficial adipose tissue, the fascia superficialis, and the deep one, and that exactly is the location where the product has to be injected. A short video, so very sterilization and antiseptic, the injection. And then with the cannula, you create the anesthetic of the part of the buttock you want. You control that with only one entry point, you can do the procedure. The 16 gauge, you enter it, is spatulate to allow to split the tissue and to go without be traumatic to the vessel. Be gentle, don't be rude. I begin by the lower part of the buttock at this part. And when the tip of the cannula is at the correct place, you begin to inject the retro tracing. And you see my fingers show the amount of hyaluronic acid I inject by going back. So more at the middle than on the extremity of the location of my cannula. And when we finish on one side, you fanning and go up step by step. And as well, a little bit at the beginning, more and more at the middle, and then a little bit less at the end. And the same from low to up. Low, put minimal of product and more, and you begin to be a little bit less, to inject less at the upper part of your buttock. So that is a MLF2. So not too superficial. And you do your fanning step by step, where you feel the location of the product. And laterally, I suggest to use the MLF1, which allows to create this nice transition in between what you have done and the location of the product, which are not injected. Can you go ahead? Okay, here is a patient. You can see that there is a lake of projection on the upper part of the buttock, on the 3/4. So very important to have a nice picture before and to control exactly what we have done. So here we have a square shape. The result just after the procedure, you can see that we create something rounder with a nice shape of the upper part of the buttock. And on the profile, we can see that the upper part of the buttock has been well injected. Oh, here you can see the shape of the buttock, the indentation before and after the roundness. And we have injected only 150 cc. So can you, yes, thank you. The A shape, augmentation only in the upper part, and that's before and after 3 months. On the profile, you can see that the roundness of the buttock is higher, and that's exactly what's our target. A round shape, but quite flat buttock. That was in 2013, after 2 sessions. And 3 months after, in 2014, other session. And we can see that step by step, we can increase and improve the quality of the result, and that was before and after 3 sessions. The round shape after the procedure and the result 3 months after, we can see that we have something which is rounder. A square shape after 2 sessions. The result we achieve, and we create more density of the buttock at the location of the buttock by itself. A difficult patient. We are at the limit of the skin quality and the limit of the stretch mark. So the deal, no, can you go back, please? Yes, the deal with the patient here was to multiply the session. Every 6 months, we do a session that allows step by step to increase the results. So that is in 2015, after 1 session. In 2018, after a couple of sessions, we can see that we really improve the shape of the buttock. In 2019, the result of what she was in 2014 and how she was in 2019 and 20. The follow-up are very important. So we don't need to do antibiotic for 5 days. Why? Because it's like antibioprophylaxis we perform for breast implant, for example. We need only to do 1 shot during surgery, and here it's the same, do only 1 shot during the procedure. Analgesic is very important, but it's not really painful, but sometimes patients need to have this antalgic. And the most important thing is really to educate the patient to follow what you say. No exercise during 2 weeks and avoid direct pressure for 2 weeks as well. And that is the most difficult things. When you do the injection in the upper part, it's easy for the patient to sit on the low part of the buttock. But when you diffuse a little bit more, then to find the correct position is not easy for the patient. So it's very rare when the patient follow your advice not to do it for 2 weeks. So that is my conclusion. The 3 pillars of the safety, the anatomy knowledge, the safe product, and the safe procedure. And to do the Botox injection, we need to, can you go a little bit, one slide ahead? We have 3 pillars. The first one is to go out of our comfort zone. That means that, of course, we do things properly, and it's difficult to say, I will change my way to do. The second thing, which is also very difficult for surgeons, and I'm sorry to tell that, but that's true, is to accept to question our knowledge. Sometimes, so we know that we don't know everything, but sometimes we are wrong. And the fact to question ourselves open the new windows and the new doors. And the most difficult thing is to accept to take side roads. So thank you for your attention, and feel free to contact me whenever you want. Thank you.
Thank you very much, Henry. Thank you very much. Please feel free to invite me anytime to Captain Tib. I will be happy.
You come when you want.
I will come. So, doctors, if you have any questions for the follow-up of the cases of Dr. Henry, please write down in the question box and we will answer later. So now I will introduce our guest, Dr. Hima Sundaram. Unfortunately, because we are not sure about the connection, she will start sharing a video with us, and after that, she will join the debate. Thank you very much, Dr. Hima. Please go ahead with the video.
Thank you, Carmelo. Actually, I'm able to be with you live. I just need to keep my own video turned off because I'm in a hotel where the Wi-Fi is not so great. So let me share my screen first of all. Can the AV people allow me to do that? I don't see the share screen. Oh, here we are. Okay. Yes, and as Carmelo said, I'm actually a dermatologist, and it's an honor to be with all of you today. And I'm going to conclude the lecture portion of our webinar by just speaking a little bit on the science and safety of HA fillers and how this relates to our topic at hand today. So disclosures, I do consult and also serve as a clinical investigator for various clinical trials. I am going to be presenting some data from studies supported by bioscience here, but as always, I'm going to try and keep my lecture unbranded whenever possible and comparative where needed. Another disclosure, I am director of these conferences, which are university-based and not-for-profit, but they do take stipends from companies, including bioscience, to provide scholarships for attendance by some of the participants. All right, so this is pretty obvious that the use of fillers must be based on evidence. And a little reminder here of that ASPS evidence rating scale for studies. And to point out that we're going to be speaking about rheology and perhaps a little about anatomy, and both of those fall under evidence category 5, evidence level 5. That doesn't mean they're inferior, but it does mean that clinical correlation is necessary in order for us to have clinically meaningful conclusions. And when we think about rheology, which is the study of the science of fillers, this is how it all started. First of all, Jeff Cablett, Gary Monheit, and colleagues, giants in our field, and then a paper that I was involved with myself. And what we were aiming to do in these publications was not to position any products above others, as tends to happen sometimes these days, but simply to pass the properties of these different products in order that we can understand how to use each of them to their best capabilities. So here's what we're going to talk about. We'll have a quick recap on filler science, which is commonly known as rheology, although strictly speaking, not all of it is rheology. We'll look at both the clinical and the safety implications. And then we'll look at gluteal fillers as a microcosm of filler science. And I think they're perfectly aligned that way. I like to think in terms of the 4 T's. First of all, the rheological tailoring of the product, tissue placement, technique, and translation, which increasingly is being done through ultrasound imaging. And gluteal fillers actually encompass all of those key considerations for translating filler science to clinical reality. And then we'll also look at how gluteal fillers can be a microcosm of filler safety. Vascular nodule complications. We have concerns about inappropriate use. One of them is the use of body fillers for facial applications, which is a big no-no. And then finally, injector responsibility. And I do want to caution you that as far as safety goes with injectables, we still have many evidence gaps that we're striving to fill through appropriate research. And because rheology can get complicated, I do, as Naveen did himself, want to leave you with my contact information. You're always welcome to reach out. So gluteal augmentation is definitely not a starter filler procedure, and product science is really key. Dr. Delmar showed us what kind of support can be achieved to the tissue with skillful clinical technique, and the science behind that, and we'll talk about that in a moment, is that we're looking at high G' fillers. G' is the elastic modulus in order to provide that 3-dimensional tissue support. And we're looking at high viscosity fillers for what I call contour stability, which means that the filler will stay put where it's placed. Patient selection, as Dr. Delmar outlined, is also key, and we need to consider the buttocks morphotype in designing our injection strategies. And in my humble opinion, it's really important to have expertise in facial fillers before we embark on gluteal fillers. Technique in this region has a profound impact on safety. There's a significant learning curve, and of course, anatomy is key. And I've put up here actually a poster presentation which was made at the Season Aesthetic Conference that I'm a director of just last June, which is from the bioscience team. And I'd like to commend them for this pharmacovigilance, for actually publishing in poster format this evaluation of safety and efficacy, because this is a starting point for safety in our field, that we have cooperation between injectors and manufacturers in order to advance safety. So let's start with our rheology recap, and I'm going to play a little video here.
The filler specimen is placed on the static plate, and then the mobile plate is put on top of that, and it rotates at a measurable velocity, generating a shear force or stress on the filler specimen, to which it responds with what is known as strain. The measurable responses we can quantify start with the elastic modulus, or G', a measure of gel stiffness and ability to resist deformation under pressure. A high G' filler will have resistance to applied force, a higher extrusion force from a needle or cannula, more tissue lifting effect, and a stiffer feel and more palpability within tissue. A low G' filler will have the opposite characteristics, being softer and less palpable within the tissue. This graph shows the variation of G' with frequency of applied force. It's a double log graph, which means that these small distances between these lines are in reality orders of magnitude. We can see here that calcium hydroxylapatite has the highest G', and then we see the sequence of HA fillers, which were approved at the time of this publication. We typically interpolate these values at a physiologically relevant testing frequency below 1 Hertz in order to correspond to the forces of gravity in the facial musculature. Now we can look at viscosity, which is measured as complex viscosity or viscous modulus G double prime, and assesses the gel's ability to resist shearing forces. A high viscosity filler will be resistant to shearing forces. It will have a higher extrusion force and a greater tendency to remain localized within the tissue, what we can call contour stability. A low viscosity filler will have the converse characteristics, being less resistant to shearing, having lower extrusion force and more tendency to spread. Viscosity also has a significant impact on integration of fillers into the tissue. The G star or complex modulus is a measure of the overall resistance to deformation, comprising a recoverable component due to elasticity and a non-recoverable one due to viscosity. It's mathematically calculated as the square root of the sum of the squares of the elastic modulus and the viscous modulus. Turning to tan delta, in brief, this is the ratio of the viscous modulus to the elastic modulus, G double prime over G prime. It measures the presence and extent of elasticity in the gel. A high tan delta means a predominance of fluidity over elasticity, whereas a low tan delta means predominance of elasticity over fluidity. Chronologically, we should start our journey with this paper from 2011, which was in many ways thinking ahead of its time. It talked about the lift capacity of the filler being not only a function of G prime, but also gel cohesivity, which was measured by gel compression and dye diffusion testing. We now know that these tests are only a partial measure of cohesivity, but they do relate to other important biophysical properties. Next, we can look at the concept of cohesivity, which is the capacity of a material not to dissociate due to the affinity of its molecules for each other. Cohesivity is considered necessary for the solid and fluid phases of a gel to remain intact and hence for gel integrity. An example of a material with high cohesivity would be honey. It sticks together and we cannot separate out solid and fluid phases. An example of a material with low cohesivity would be couscous or semolina or cream of wheat. This is non-cohesive or dispersive in that the particles separate out. The publication with the validated cohesivity scale described the stress testing of all FDA-approved AHA fillers at that time under identical conditions. And from this, we developed a 5-point validated scale ranging from non-cohesive or fully dispersible all the way through to fully cohesive.
All right, so that's rheology in a nutshell. And don't worry, I'll give you a slide in a moment that simplifies or summarizes everything. It's really quite interesting to me that this cohesivity concept, which we know, of course, is important for breast implants, caught the imagination sufficiently that the American Society of Plastic Surgeons decided to release this paper to the national media. So then we had beauty magazines also getting interested in rheology, which I really think is an indication of how much this field has come of age and how far we've come in understanding how science underpins everything we do clinically. All right, so here is the simple slide if you want to just take this home with you. Elastic modulus confers tissue lifting or tissue support. Viscous modulus and complex viscosity manifest as product spread. And cohesivity impacts product adhesion, which is the affinity of the components of a filler gel for each other. And then those secondary calculations, complex modulus is a measure of resistance to deformation, and tan delta is a balance of fluidity versus elasticity. And keep in mind that a higher tan delta means that a product is more fluid. How can we translate this interesting research to clinical reality? Well, first of all, we can see that cohesivity and viscosity together predict tissue integration. When we have a low viscosity, higher cohesivity product, it spreads out like the food analogy I gave you, like honey within the tissue. We can see here the Alcian blue staining showing HA distribution within the dermis. And we can see that same pattern on high frequency ultrasound imaging. The echolucent area here, the dark area, is the filler that is spread out homogeneously through the dermis. On the other hand, we can look at a high viscosity, low cohesivity product and see that it stays more as microboluses. We see here the blue Alcian blue staining. What that means is that this type of product would be more suitable for implantation deeper down into the subcutaneous tissue rather than the dermis. And the intermediate product has intermediate distribution on histology and ultrasound imaging. One question I get asked quite often is, what is the role of cohesivity here? You know, we can understand that viscosity controls how much the product spreads out. What cohesivity does is it keeps the solid and fluid phases of the filler gel together. So it's both of these properties that are important. Another example of how we can translate that research to reality is to think about what I call the car analogy, that we're the drivers, the injectors who are driving this car, which is the product that we have selected on the basis of its engineering along the road of patient and tissue considerations. So the science of the product, the car in this case, is directly related to the results we get. And we must, of course, also understand our responsibility as the drivers of that car. And as I mentioned in the cohesivity video, this is stress testing in the same way that a car is driven for a short period of time during testing at very high speeds in order to assess its likely performance over a longer lifespan. We do the same thing when we're rheologically testing filler products. So let's close now by looking at gluteal fillers and how all of this rheology ties into what we're doing here. Well, rheological tailoring is the concept that we can match the scientific properties of the filler to the desired procedural outcomes. And for gluteal augmentation, we're looking at higher G' fillers to confer volume efficiency and tissue lifting. And there's also a nice balance between G' and cohesivity, which impacts moldability of the products. In these publications, I define two types of volumetry based on rheological understanding. And the type of volumetry we need to consider for gluteal augmentation is deep support volumetry, where we're using these high G', high viscosity products. The cohesivity may be a little bit lower than with the more superficial products. And these are large particle HA gels, which is why they have high G' and high viscosity. We know from a safety perspective, it's very important to inject these products above the muscle. And what we achieve with these high G', high viscosity products injected in the right way is more tissue projection than tissue expansion. And because of the high viscosity, we have a contour stability where the products are less likely to be displaced. The anatomical reasoning for this was provided by Professor Kung Huang and his colleagues. This was quite a surprise to me that he published this as a support for the papers that we had published, showing that if we are injecting above or below the membranous layer of the superficial fascia, we can get either superficial flow or deep support volumetry, respectively. But as I mentioned, for the gluteal region, we must be above the muscle from a safety perspective. So the product that we've seen in Dr. Delmar's video, let's just take a look at the rheological data here. And we can compare that with products from the same company that are used for the face. And what we notice immediately is that the G' is higher for these two products, which are used gluteally. That's the MLF1 and MLF2, or for the body. So that's going to give more tissue lifting effect. I've also highlighted here the tan delta, which is the balance of fluidity versus elasticity, because we see here a lower tan delta for the body products than for the facial products. And what that means is they'll tend to flow less, and they will tend to provide more elasticity or resistance to force, which of course we need in the body and in the gluteal region. I mentioned earlier this disturbing trend of injecting body fillers to the face. This is an extreme example of rheological mismatch. You can imagine that if we take these products, which are firm and which have a relative lack of fluidity, and they are injected into the face, then there's a much higher risk of nodules and inflammation. There's also a compromise of sterility if these products are being transferred from the original syringe in which they were manufactured into another syringe. Let's look now at some ultrasound imaging. This is a collaboration with Dr. Brambilla and Dr. Millefiore. And we can see here the cannula passing above the muscle. So here's the skin, the epidermis and the dermis, and down here is the muscle, the gluteal muscle, and that cannula is nicely placed above the muscle in the subcutaneous tissue. And we see these lacunae or lakes of echolucent dark-colored HA filler being deposited exactly in the right plane. And we can see 24 hours afterwards, we're achieving a nice, smooth distribution of the product. Here again is the muscle down below. Here is the epidermis and the dermis above, subcutaneous tissue with that HA filler. So in conclusion, let's put it all together. How can we be integrating science with filler safety? First of all, we should, rather than be focusing on one individual scientific property when we're selecting our products, I like to think of what I call a biophysical profile, integrating all these key properties in order that we can be using the right product for the right clinical application. And if you're interested to read more about that, I'll refer you to these publications. How does this tie into what Dr. Delmar talked about, which is the patient side of the equation? Well, here's a nice little schematic. We can look at this biophysical profile. That is going to impact how the product flows in the tissue, how it integrates, even its biostimulatory capacity to generate collagen or elastin. We put that together with the patient side of the story, and that's how we can get the best and the safest treatment outcomes. Filler science significantly impacts all the features that injectors have been shown to be concerned about. And we can see here, obviously, that safety is the #1 consideration, followed closely by predictable results and biocompatibility. This is really what we are working on when we try to translate research to clinical reality. The fact that we have the bench research, and I've color-coded here for the evidence level, we have to bring that through to clinical practice, and it's the real-world studies and the clinical trials that are going to do that for us, and imaging is really our future in terms of that important translational pathway. We still have some evidence gaps with respect to gluteal fillers. We need to determine safe volumes. We need to understand how product displacement relates to injected volume as well as the product science. We need to understand how to predict water uptake, and we need to comprehend better the long-term results of the sequelae, including the very beneficial improvement that HAs can mediate on tissue quality through various signaling pathways, including CD44 and probably CD68. These are cytokine cascades. Safety analysis is difficult because it also is evidence level 5. It's retrospective and what I like to call the 3 Cs: case reports, consensus, or expert opinion, and these cadaver and bench studies. And we need, again, to be working on the translational research that can enable us to raise the evidence level for safety analysis. In doing this, all safety stakeholders must unite. Yes, we must unite as practitioners to be comprehensively reporting complications, either that we experience or that we see when patients consult with us. We need to be aware of the challenges with publications in this arena. And I'm going to leave you again with this poster presentation to commend all companies that openly publish their post-market surveillance data and enable us to objectively assess their product safety. And again, I'll leave you with my contact information, and these are a few papers in the plastic surgery literature that I've been involved with that relate to filler safety. Thank you.
Thank you very much, Dr. Sundaram. Thank you very much for the very scientific and clear explanation about the hyaluronic acid fillers. Mostly when we're going to use fillers like for body contouring, like Hyacop. I would like to say something. Using these fillers since 5 years, and honestly, I tried other fillers, but the one from Bioscience, MLF1 and MLF2, and the combination of both of them, including also the facial line, so far they gave me very nice results. And in terms of safety, always according to the doctors and patient selection, because the patient should select the right doctor, but the doctor should say no sometimes. So I really like this filler, and I would like to highlight also that sometimes, again, we have to say no to the patient according to the skin characteristic or to the body shape. And I would like to involve you doctors and going through a few slides now, a few pictures, starting with Dr. Brambilla. And if they can start my slides, I would like to know how you react and how you treat this kind of patient, or how you say no to this patient when you decide that this is not a good candidate. So let me see if I can go through. Yeah, let's start this open discussion. So let's see which are the exclusion criteria for the patient. Massimiliano, if you don't mind, would you like to tell us how you react and what you do when you have patients with severe lipoatrophy, like poor tissue cover, ptosis of the lower third of the gluteal area, or severe skin laxity?
I really think, can you hear me?
Yep.
Right. Hi. So I really think that both Dr. Denmar and Dr. Sundaram, they pointed out perfectly the two main key points of such a product. So the first one, talking about the safety injection, and the second, Dr. Sundaram, about the rheology. And Hema Sundaram pointed out, again, tissue projection versus tissue expansion. And what she said that is extra interesting for me is the concept is that we have two different products, one who may better improve the projection, and the second one, the tissue expansion. So of course, cases like those are not the best cases to be treated with hyaluronic acid, but if you play with good sense with the products, you may improve the shape and the tissue quality. So of course, those are not the best patients, but I cannot say that those are patients to avoid completely. If you talk with the patient and you're clear about the results that you may achieve, and we are talking about slight improvement, you may inject hyaluronic acid in those patients, but with being extremely careful about the patient selection, talking a lot on patients and about the possible outcomes. So in patients like those, I would or refuse to treat, or on the other side, treating with products that can get better expansion of the tissues where needed.
Max, I think that you...
yeah, please, Emma.
Sorry, Carmela. Max, I agree with everything you've said. These are patients who really need our help. And if we can help them, then we should try to do it. And it is, first of all, yes, the key scientific properties enable us to balance tissue expansion with tissue projection. And clearly here we can see the need for surface improvement, relatively superficial improvement, as well as the deep in these patients, which is where the tissue expansion comes. Those will be the softer, more flowing products relatively to the firmer, deeper implanted products. The other consideration here, and I wonder if you would agree with me, Max, is we have to be extremely careful about the inferior pole, the lower pole. And we would also want to be sequentially treating these patients. We don't want to be injecting a large volume in one session. Because the tissue quality is poor, there is a greater chance that the filler product may sink down under the effects of gravity and that we may get a suboptimal contour. So this is the type of patient where we would be proceeding with relatively smaller volumes, and in my opinion, and taking it sequentially. And we'd also be very, very careful about the inferior pole and not placing a significant amount of product there again because it's going to sag. Would you agree with that?
Yeah, I totally agree. If we look at the sequences, so on the left side, on the first slide, I really think that we may achieve a better contour injecting quite deeply on the deep hip. And then on all the others, the main problem is skin laxity. So I totally agree about the concept about doing and performing the procedures in several times, waiting at least 20 days, 1 month, one procedure to the other. And yeah, so I think we may treat, but being extra careful about what we are doing and patient selection and the price of the product as well, because there is another limitation that we have to talk about, that is the cost benefit of the product, of the treatment.
If I may, I would add something. Yep.
No, you go ahead, Carmelo.
Yeah, just 1 second, because if you see also, yeah, patient selection is a must, of course. But the first picture where we talk about massive liposuction or wrong liposuction, we have to be very, very careful, because most of the time we have also skin retraction by fibrotic tissue. So the filler in one session for sure won't be able to give projection or expansion of the skin. But I try myself, and you see after 3 weeks, 1 month, like you just said, Max, you will be able to inject more. So slowly, you can reach some results. And one more thing about, yes, cost benefit, don't forget also the patient expectation. They come to us with pictures, coming with Instagram, oh, I want to be like that. While unfortunately, maybe sometimes we have to say, it's not possible because the shape and the skin quality and texture cannot be the same of the picture you're showing.
Yeah, but I think that Dr. Dermal already talked a lot about that. Yep. I mean, we are doctors, and we know how to select our patients, and we are not just Instagrammers. So we are talking about science, and we are not talking about just fake results. So I think that talking clearly with the patients and being honest bring to our office happier patients and avoid disasters or miscommunications and complications and regrets.
Agreed. And now, Henry, if you don't mind, let's see the other. Let's go ahead. Whenever we have patient with gluteal bends or saddlebags, how you would treat this patient? What you would do to this patient?
Okay, the situation are quite different. The first patient, we have massive external fat pad excess, and the roundness of the buttock is a little bit not well designed. So how can we help that patient? Immediately, what I think is to remodulate, to do a contouring, a body contouring. That means that is not a good indication for filler. Why? Because you need to put a lot to have a mild improvement on the upper part of the buttock. And finally, the body contouring will be not really, that is for the first patient, not extremely important. So for me, it's not a good indication for filler, but more for surgery. The second situation is certainly a consequence of massive liposuction. And as well, we need to improve this part of the body. And for the upper part, there is nothing to do. it's more a surgical surgical indication than a filler indication, where you can really not improve that. And what can we do with surgical surgery, or doing a Botox lift? Things I don't like, because that creates scar, and the patient don't like scars. But a mild liposuction with fat grafting and skin retraction with external or internal EVD techniques will improve a little bit. And I agree with all of you when you say, when a patient complains of something, try to find the correct solution. Not to say no for no, because when you say no like that without good explanation, the patient feel like to be aggressed.
And sorry, Henri, in certain cases, we could also integrate the filler injection after the surgical procedure.
You are right, but it's a process. And the question here, can we do something with only filler? It's certainly no. And
okay.
The same thing for here. We have first to do a body contouring, and the filler has nothing to do. Maybe after fat grafting the result is not correct, we can improve, as you say, Carmelo, with filler,
yeah.
but it's not our first intention. And the third one, I'm a little bit embarrassed, because if she refused to have a body contouring with the liposuction, which is a very good indication, we can maybe improve a little bit the upper part of the Botox, but there is no dramatic improvement. So the cost will be very high for a few improvements.
Perfect, I agree. Thank you very much, Dr. Delmar. Let's go to the other slide. And here we see cases of cellulitis, which could be superficial, deep, fibrotic, first stage, second stage. Dr. Sundaram, how would you treat this patient, or how would you exclude this patient?
Thank you, Carmelo. Well, this again is a consideration of tissue quality. So we have to take into consideration two criteria here. One is that HAs are very powerful in terms of improving tissue quality. You know, we talk about non-HAs and use this euphemism biostimulator really to mean only non-HAs, but that really is more marketing than science. If we look at the science, HAs, of course, do mediate significant improvement in tissue quality. There's one signaling pathway through CD44 receptors. HA binds to those within the tissue and has the capacity to stimulate collagen and elastin. And now we're recognizing other signaling pathways as well within the tissues, all the way from the skin down to the supraperiosteal region, such as CD68. So with this in mind, it's possible to take a patient like this and to use a wide cannula, wide for safety, and gently release some of the fibrous connections here, or adhesions, because that's what cellulite is. You know, we looked at the post-surgical patient previously, and there's an analogy here in that we have these fibrous septae which are dimpling the skin, and we can cautiously and gently use a cannula while we're injecting to release these tetherings. Now, we must be very careful, firstly, because we have to stay above the muscle from the perspective of vascular safety, and we also don't want to traumatize the whole area such that we lose support. But with a gentle, I certainly have treated this type of patient with this technique and using a cannula and a gentle dispersal of the product. And again, I would recommend that we use sequential sessions with smaller volumes rather than trying to put it all in at once. The other consideration is to have realistic patient expectations. Cellulite is physiological for most, if not all, female patients. It's a simple matter of estrogen balance, the connective tissue therefore being a little bit less supportive than for men. It's an issue of the orientation of the fibrous septae, and the general skin quality particularly is we have that estrogen balance. So we have to tell these patients that they may not achieve what I think is a photoshopped appearance right on the left-hand side. this is not achievable for many patients, but with adjustment of expectations and the right technique and the right product selection, it's possible to satisfy many patients. Again, I'll turn to what Max said previously, which is that we need to consider the balance of tissue expansion versus projection in selecting our products. And here I would use a balance of both.
Yeah, perfect. And I would like to add something else, because, you know, Bioscience made this filler, both of them, MLF1 and MLF2, which could be very good also for a combination of the two. Sometimes mixing the superficial fat layer, the MLF1, even if you go on the hips area, and then in the deep tissue, you go with the MLF2, in, let's say, expert hands, could lead also to results like this one, where at the end, I don't know if they can show the before and after, because these, of course, are patients with stretch marks, with poor skin texture, but at the end, in good hands, you could have also this result here, whenever you have skin elasticity, whenever you inject in the right way.
Carmelo, I would like to add that we have to be really aware when we have cellulite, I mean, heavy cellulite, important cellulite, because in some cases, tissue expansion may worse the condition of cellulite, because when you enhance the expansion, but then you have some deeper indentations and fibrosis, and then you expand the fibrosis in certain areas, they may worse. So
you create chronic inflammation as well.
Yeah, what Dr. Sundaram said is crucial. I mean, when you have deep indentations, you have to free gently the indentation with a needle in order to let the expansion do the job. Yeah. Otherwise, in those difficult cases, you worse the condition instead of giving an improvement.
Yeah, Max, that's a really important point, and thank you for underscoring that. It's particularly important for female patients because of the orientation of the fibrous septi, which is what predisposes to cellulite. So we do have to free those up before we're injecting the product. Otherwise, as you said, we can simply be injecting into those little pockets, which are bounded by the fibrous septi, and actually get worse results. So beautiful. Yes, as I said, we need a balance of tissue projection and tissue expansion. And we do have two products within this portfolio that can give us that.
I agree 100%. And keep talking about safety, I would like to ask to Max, to Dr. Brambilla, about the responsibility of both, of the patients and the doctors. So how we can be responsible towards the patient, and how the patient should be responsible about the procedure.
Can you hear me? Can you hear me? Yeah,
yes,
can you hear me?
I'm
sorry.
Yeah.
Internet was out. Yeah, I think that we are always responsible for the patient. And okay, there are some responsibilities of the patient, but most of the responsibilities are our responsibility. So I think that Dr. Delmar was extra clear, and I agree so much about the safety profile of his presentation. So it means that antibiotic is crucial in order to avoid or to reduce the infections, and it's our responsibility to do it in a safe place. You cannot do it in places that are not proper places. You have to perform those procedures at least in an extra clean environment, and operating room or surgical ambulatory whatsoever, but in a sterile conditions, sterile gloves. I mean, we are not injecting just 1 cc, and even with 1 cc injecting into the face, we have to do it under good rules. But when you inject those volumes, you have to be extra safe, and then is our it's our rule to do it properly. And then what he highlighted again about pain control is crucial if we want the patient to come back. So I totally agree about that. And then about patients, of course, patients have to avoid avoid those things that we always say. So they have to avoid exercise a little bit for a while. They have to avoid to expose to extra temperatures for a while. But we cannot ask to a patient to not to run a proper life for a month after an easy injection. So again, most of the responsibility, % of the responsibilities are our responsibilities, I think.
Perfect, Massimiliano. Thank you very much. And I would like at this point to open the question and answer. And the first question is for you, if you don't mind. Dr. Barreto, Lisette Barreto, sorry, Barreto, she asked something and she said, beyond the application of the product, what about the safety in the long term? If you can tell us something.
Yeah, well, I'm injecting hyaluronic acid since so many years, and before the products of biosciences, other products. So I think that if we do it under good rules and good education and knowledge of the product and rheology, we can stay extra safe with those products. I mean, adverse events and complications may always happen. I mean, we are doctors and we perform surgery. We know that if we do surgery, it's just a matter of numbers to have a complication. But if we are able to reduce it to a minimum term, it's a procedure that we may do. So doing it safely and not injecting super high volumes and selecting well the patients keep us safe with happy patients.
Perfect. I agree. I would add that to avoid, of course, trauma, here in the Middle East, we have sometimes the problem of the horse riding, for example, which is a continuous and chronic stimulation of the area, which if you inject a large amount of filler, can cause problem in the long term, problem which we can solve easily. Thank you very much, Dr. Brambilla. And I would like to ask something to Dr. Del Mar. So from Dr. Senera Hoxha, I believe from South America, something like that, they're asking if you combine in the same procedure sometimes MLF1 and MLF2, and if you achieve better result with the combination of the two. Dr. Del Mar.
I always combine both of the product 2 and 1. As Emma explained us, I'm the first fan of Emma. It's important. We can observe that the rheology of the two products are not the same. And if you want to build a nice shape of the buttock, we need to have, how can I say that, transition zone in between the place you push your MLF2 and the zone where you don't inject. And the MLF1 can create this transition zone. Also, there are some zones where the subcutaneous fat is thin, and it's better to use MFLM1 than 2, because then the product spread a little bit more and the shape are nicer.
Perfect. Thank you very much, Henri. And one more question for Dr. Hema Sundaram from Eklitiab Osama. This is a nice question, actually. As there are now many brands in the market claiming efficacy as a body filler, how we can choose the right one for the safety of the patient?
That is a good question. It comes back to what I said at the end of my lecture. We need to be calling upon companies to publish their safety data. Any company that's responsible in our field will be motivated to partner with us as injectors in order to assure safety of patients. One of the challenges we have with non-surgical aesthetics in general is, sorry to say it, industry is the tail wagging the dog of our field. This field, unlike surgery and unlike therapeutic dermatology, this field started off with industry. And we recognize the valuable contributions that research motivated industry makes to our field, but we have to always pass research and evidence and science from marketing. So every product out there, every company is going to claim that its products are superior, or its products are safer, or they're better or more efficacious. We need to ask them for the data behind those claims. And we need to look particularly at the long-term safety data. So I showed you a poster from the company that is supporting this webinar, that's Bioscience, which is safety monitoring. And it's not as sexy a poster as one which shows all these nice before and after results, but it's a poster that is extremely important in terms of showing the company's commitment to safety and best practices and partnering with injectors to help patients stay safe and achieve the best results. In terms of how we make a schematic for achieving those safest and best results, it comes down to that graph that I showed you, where we're integrating the product science and what that implies for how the product behaves with the patient characteristics.
Thank you very much, Dr. Hema. Thank you very much. Well, today's session is over. I would like to extend all the thanks everyone from Bioscience team to attend this webinar of the aesthetic review, the 5th session. I would like to thank you, doctors, Dr. Brambilla, Dr. Delmar, Dr. Sundaram, Dr. Nabil, who had to left because he had family duty. I believe all of us we have as well. And thank you for everything. Thank you for sharing your knowledge and your experience. I would like to thank also our all attendants here online. And please, if you have any question that we didn't answer to, drop it in the question box and we will answer to you by email, or send us a message on our socials, and we will be very happy to answer to you and then give what the right answer you want to hear. Thank you for everyone. Have a lovely day, and looking forward to see you all again. Thank you. Goodbye.
Thank
Merry
you.
Christmas.
Bye-bye.
Thank you.
Merry
Happy
Christmas.
holidays.
Yeah.
Happy holidays to everyone.
Thank you.
Enjoy. Bye-bye.
Bye.
Bye.